Good afternoon, judges, and good afternoon, everyone. So, I'm thankful to DOS to provide me this opportunity to present my paper. So,
Yeah, so if we finish this in 5 minutes, then we have good time to finish the rest.
so I'll be presenting posterior segment complications in two eyes, which occurred following amyth glaucoma valve in eyes which are previously vitrectomized. So I don't have any financial disclosures, and ethical clearance was obtained from the hospital in which I work. So there were severe vision-threatening posterior segment complications which developed following amyth glaucoma valve in two eyes who had undergone previous vitreous surgeries. Both these eyes had intractable glaucoma, and the management of the complications will also be discussed. So the first case was a 63-year-old female who had undergone vitrectomy 3 months back for a non-resolving vitreous hemorrhage following a complicated cataract surgery. Her best corrected visual acuity was 6/60. Her intraocular pressure was 42 on maximum anti-glaucoma medication and acetazolamide. Anterior segment examination showed a slightly decentered IOL and presence of superior and temporal iris atrophy. The fundus, the optic disc had a cupping of 0.7, although the neuroretinal rim was also showed thinning. So, amyth glaucoma valve surgery was planned and performed by the glaucoma specialist in her right eye. However, on the first post-operative day, the patient had severe hypotony with the pressure less than 4. The patient developed a choroidal detachment, which did not resolve despite systemic and periocular steroids, and rather it increased, and at 3 weeks, the patient had developed kissing choroids with the PL positive and PR was accurate. So I'll discuss the management later. The second case is an 8-year-old boy who presented with severe pain and vomiting for 2 days. His intraocular pressures were more than 50 mmHg. The child had previously undergone a pars plana vitrectomy 3 weeks before for a dense vitreous hemorrhage in his right eye following a blunt trauma with a cricket ball. His vision was hand movements close to face and the PR was inaccurate. Anterior segment examination showed severe corneal edema because of the raised intraocular pressure. There was presence of traumatic mydriasis. A subluxated clear lens was observed. The subluxation was more than 90 degrees. The anterior chamber was deep, however, the angles could not be seen with the help of gonioscopy due to the presence of edema, and a diagnosis of angle recession glaucoma was made. The fundus was very hazily visible, but however, the retina appeared attached. The patient was started on maximum anti-glaucoma therapy, and despite treatment, his IOP was not controlled, and the patient complained of severe pain. So after 2 days, amyth glaucoma valve surgery was performed under general anesthesia. Post-operatively, the patient had a relief of his symptoms. There was a relief of the pain and vomiting. However, the patient developed again severe hypotony, and this was his fundus picture at day 1. He has got multiple islands of pre-retinal hemorrhage. On OCT, we can see a hyperintense membrane, and below that there is shadowing. So probably all these bleeds were sub-ILM, and also the patient had a history of previous vitrectomy. So this is the fundus picture at 1 month. We can see that there is further clotting of the blood. At 1 month, there is formation of clot and there is thickening and contraction of the overlying ileum. The vision has reduced to 3/60. This blood may be toxic to the underlying fovea. So in both these cases, what to do? Observe them would probably cause no benefit, but to operate again is very risky. The patient may not have any benefit. We had to counsel the patient. The second patient also required general anesthesia. But however we counseled the patient, we went ahead for a surgery in both the cases. So this is a video of the first case in which I just prolapsed the AGV tube and ligated it and placed it back, so if it required, we could open it later. And then the drainage of the choroidal fluid was done by a modified sclerectomy technique in which a perpendicular incision is made 3 to 4 mm from the limbus, just like we make a trocar entry. And then the second incision I'll make at 45 degrees slanting, when you can see a gush of fluid will just come out. You can see a gush of fluid coming out from the choroid, suprachoroidal space. So this will help in a self-sealing of the wound. So this was the end point in which no more further fluid was coming. So with this technique, the suprachoroidal fluid using this modified sclerectomy technique was drained successfully. The patient 6 months post-operatively now has a vision of 6/36. Her pressures are controlled. There is no choroidal detachment. But however, later she may require an opening of the AGV tube. But presently her pressures are controlled on medical management. So this was the second case which had this. The sub-ileum bleed. You can see the ileum is very thickened, and I just tried to remove it, but I was very scared because even slightly more traction on the ileum could have caused a retinal break. So I'm just de-roofing it, and then I'll use a back flush to remove this altered blood and just try to slightly lift this thickened ileum. And I think I was very lucky while doing this case that nothing went wrong, and I could very successfully just removed the altered blood and the thickened and the taut ILM, which is adhered to the underlying retina. So again, I use the ILM forceps, and I'm using a tangential force and very gently trying to just tease out this membrane over the area of the fovea. And again, I was very lucky that the whole of the membrane came out without causing any damage to the child. So this is just slightly further enlarging the ILM so that does not cause any attraction on the fovea. And this was followed by the removal by a backflush of the remaining blood. So this is the post-operative picture at day 1, and this is at 1 week. We can see there is a clear fovea. The vision has improved by 6/9 parts. This child is under follow-up with me. After 1 year, the child has got a clear fundus. The OCT shows a normal macula, normal contour, and we can still see that the subluxation is persistent. There is a clear lens which is showing a subluxation. So just to conclude, AGV surgeries in vitrectomized eyes can lead to severe vision-threatening complications, like in our cases. One case developed kissing choroidal detachments, the other developed a non-resolving sub-ILM bleed. The absence of vitreous support in such cases could be the possible cause of the sudden decompression and severe hypotony leading to these complications. But however, luckily, both of our cases were managed successfully in our study. Thank you very much.